This is Lecture 4 on Chapter 22. A Meckel Diverticulum is similar to a diverticulitis. You have a little sac of intestine, and it can get infected, it can rupture and bleed. The difference is a Meckel Diverticulum that is a remnant from the yolk sac. Remember, the embryo is first in that yolk sac, and that yolk sac makes this diverticulum, this pouch hanging off the intestines. The most common presentation is painless rectal bleeding. So most people don't know they have this. They say many of us have one and don't even know it. But if it ruptures, you get painless rectal bleeding. Occasionally it can be painful or infect or obstruct, but usually it's the painless bleeding. And so they go in and surgically remove that little protrusion, that diverticulum. So there are some things in our book that you don't need to know for the PEDS exam, and that's inflammatory bowel diseases, peptic ulcers, hepatitis, and cirrhosis. You will do all of those in adult med-surg. Biliary atresia. If you think about the word atresia, it means it's not there at all, or it's totally non-functional. So this is the bile duct doesn't work. It's totally non-functional. So what happens is you are still making those enzymes and things in the liver, but they're not going anywhere, so they stay in there and do damage and destroy the liver. So usually what you're going to see is jaundice at about 2 to 3 weeks of age. This differs from physiologic jaundice because that's at more like 3 days of age. So this happens a little later, but you have this jaundice starting a little later, the pale stool and dark urine because you don't have the bile going into the stool, and your body's trying to get rid of bilirubin in the urine. So if this is not treated, it destroys the liver, and they rarely live beyond 2 years. If it is treated, the earlier they have surgery, the better. But still most of them will need a liver transplant at some point in their life. And the treatment is a Kasai procedure. So this is our stomach here, here's the liver. So they take the intestine and cut it here and then attach it up to the liver to make this as if it was the bile duct, and then attach the end here onto the intestine here. It will work okay for a while, and for a while for enough to mature and grow, but probably not for your entire life. Most of these people will need a liver transplant at some point in their life. Cleft lip and cleft palate. This happens early in utero. The lip should merge, should develop 7 to 8 weeks of gestation. That palate fuses 7 to 12 weeks of gestation. As you can imagine, when a child's born with a cleft lip, it's very visible. They don't look like the cute, perfect baby the family is hoping for. So it's very hard on parents emotionally. The palate causes a lot of problems, feeding problems. Actually, the lip and the palate cause feeding problems. And then the palate vocalization is an issue. So here's a child who's just had his lip repaired. And you can see we don't want him to rub or pull on the suture line, so we've got him in elbow restraints. So he can move his arms around, but he can't bend his elbows, so he can't reach up here and rub on this or pull on it or tug on it. And they try and do kind of a zigzaggy incision rather than a straight line, and they get a much less of a scar. So the cleft lip repair is done first. The book says 2 to 3 months of life, but at children's they do it earlier than that. They like to wait until they're 10 pounds at least, but then they like to do it as soon as they can. And they do such nice plastic surgery anymore. There's minimal scarring because they use that Z-plasty procedure. while that suture line is healing, we want to make sure it's not getting tugged or stretched, and so the Logan's bow kind of protects it. And then we also want to do those elbow restraints so they're not rubbing or pulling on it. The cleft palate's not repaired until they're more like 12 to 18 months of age. And if you think about that, they should be having some words by then. And it's hard to talk if you can't push your tongue against the roof of your mouth because you have no roof of the mouth. Also, just sounds come up through the vocal cords should bounce off that palate, and the palate's not there, so it does affect their speech. But the biggest problem is feeding. You can imagine anything that goes in the mouth, if the tongue is pushing up, which is the normal action of sucking, it pushes it right up into the nose. So we've got to be careful with feeding. We're trying to get formula as far back in the mouth as we can so it doesn't go up into the nose, and they're at high risk for aspiration. So sit them upright and then ESSR, enlarge the nipple because they're not going to get a good grip on it. They can't make a good suction. Stimulate the suck, watch that they're swallowing, and give them rest. They've got to have rest in between because a lot of times stuff does go into the nose. We've got to clean the nose and let them catch their breath. They swallow more air than the average baby, so we've got to burp them more frequently. This is still a normal baby, and babies have a need to suck, so we want to make sure we are helping them meet that sucking need. That's important just for comfort as well as for muscle development of the mouth and to be able to chew and swallow and speak as they develop. There are special bottles for cleft palate feeding. They're squeezable, so as you see that baby sucking, you actually squeeze it a little bit. They also have a one-way valve, so if the nipple gets compressed at all, it's going to squirt into the baby's mouth and not just squirt back into the bottle. Some families, though, find that hard to use, and they end up syringe feeding or spoon feeding with thickened formula. So really, whatever the family finds that they're getting adequate fluids and nutrition into the baby is what we're going to have them do. Esophageal atresia. Remember, atresia means it's not there or it doesn't work. So we have an esophagus that has a portion that's not there or is non-functional, and a fistula, a connection between the trachea and the esophagus. This sounds bad, right? And it is. So in utero, that esophagus did not develop properly, and it connects to the trachea. So what goes into the mouth goes into the lungs. This is why we want to observe every baby's first feeding, because if they have a tracheal esophageal fistula, they are going to cough, gag, choke, turn cyanotic because everything they just ate went into the lungs. If it's a concern that they may have a tracheal esophageal fistula, we need to put them NPO. That neonate is NPO, which means they must get IV fluids. They'll get dehydrated otherwise. We're going to need to suction to try and get out maybe what already has gone in there or prevent them from aspirating more. And then position them upright so they don't aspirate, because what's in their stomach, or just babies don't have as much saliva as us, but they have some, and we don't want that going down into their lungs. And we're probably going to have to treat with antibiotics for aspiration pneumonia. And this has to be repaired surgically. Here's the book has a picture of the different types. This one, it's not connected between the stomach and the esophagus. Here, there's no connection. There's this gap in the esophagus, and instead it connects into the trachea, right? And here's the bronchi down here. This one, you still have that dead end of the esophagus, and the lower esophagus connects to the trachea, which means anything in the stomach can reflux up and go right into your lungs. This one, it doesn't have a total dead end to the esophagus, but still what you swallow is going to go into the lungs. This one just has the fistula between the two. So some of what you swallow will go into the lungs. This is the most common type. It's got that dead end and then the connection between the lower esophagus connects to the trachea here. And so with this kid, they usually will want to put down a Salem sump, right, your section, into that dead end so that what's there, we're getting back out, and drain the stomach as well, because anything that reflexes here gets aspirated, and keep them upright. On rare ones, mostly there's enough esophagus that it just needs to be reconnected, but if there's not, they may have to they'll take a piece of the large intestine, the colon, and use that to make esophagus. Moving on to hernias. A hernia is a protrusion of one organ through some opening. The concern with hernias is if that organ, a loop of it goes through and then gets stuck. So that's called strangulation. It goes through, it swells a little bit, and now it can't get back out because it's swollen. That swelling pinches off the blood supply, and now that loop ends up ischemic. So there's some different types. A diaphragmatic hernia is the intestines go above the diaphragm. So in utero, the intestines developed on one side where the lung should have been developing. And this is a critical illness that you're going to see right at birth. You're going to see respiratory distress because this baby has one lung that very little lung tissue developed because the intestines are where the lung should be. An umbilical hernia is usually not a big deal and usually will close by itself. A baby has very relaxed abdominal muscles, and when they cry and increase their intra-abdominal pressure, a loop of intestine pops out right but where the umbilicus is. Right? This is the baby. They cry. They have an outie, and when they cry, it gets really big. As long as it's soft, and reducible, you can push it back in where it should go. It's not a concern. We just wait for those muscles to strengthen. An ophthalmocele is similar to a gastroschisis. Gastroschisis means all of the intestines develop outside of the abdomen. And an ophthalmocele, just some of the viscera that should be intra-abdominal develops outside, but it's covered by skin or peritoneal sac, where with gastroschisis there is no covering. And I have some ugly pictures coming up here. Well, here's a diaphragmatic hernia. So you can see it pushed the lungs over to the side. Not a whole lot of this left lung develops, and they're usually on the left just because of the way things are, the anatomy. And so he's missing that lung. Here's the umbilical hernia, right? Here's the abdominal wall here, and this was your umbilicus, and as you cry, oh, that loop pops out. And here's the ugly picture, gastroschisis, so all of the intestines develop outside of the abdominal wall. And the issue with gastroschisis is you can't just stuff that back in. If you stuff it back in quickly, when in utero, it wasn't all in there. You're going to pinch off the blood supply. You're going to make such high pressure in there. You pinch off the blood supply, and tissue that gets no blood dies. So we put it in slowly. So this intestine is in a silo that's being put back in over a number of days. So hypertrophic pyloric stenosis, this is the pyloric sphincter, which is the base of the stomach, overdevelops. It usually happens about 6 weeks of age, and these are the kids that have projectile vomiting, and projectile is not a joke. People sometimes use that term. You have not seen projectile vomiting until you've seen a baby with pyloric stenosis. I mean, this is where the mom puts them up on the shoulder to burp them, and it hits the wall behind mom. So they will start this projectile vomiting. They are hungry, they eat, and they throw up everything. So they get dehydrated. So we have to do surgery and just snip this pyloric sphincter at the base of the stomach here to let it get big enough to let things flow through. And then we start feeding them again shortly after the surgery, and they do